up next we've got Richard Caroll, who is an endocrinologist. He's flown up from Wellington today. He's arrived with his suitcase and raced across from the airport to come and present to us. He has a very special interest in neuroendocrine tumours and tumour groups, but particularly in the hereditary side of things. I know he runs clinics in, is it 3 different centres?
Yep.
And I'll let him I'll let him explain further his special interests and go into more detail on the hereditary NET syndromes. Thanks, Richard.
Great. Thank you very much.
Yeah, sorry.
Cheers. Thank you. Great. Well, thanks very much for inviting me along, guys. It's great to come meet everybody. So I'm an endocrinologist, so hopefully lots of you will have met an endocrinologist previously. Many of you won't have done. For those who haven't, we deal with issues that affect hormone secretion effectively. And increasingly nowadays we're dealing with endocrine tumours that affect or cause hormone secretion. And my particular interest, as Avril said, is in endocrine tumours and the genetics around those. So we're going to talk today about some of the hereditary NET syndromes, in other words, things that can be passed on within families. And as we've already heard from speakers today, that's not the majority of neuroendocrine tumours. Our understanding in this area is evolving all the time, but at the moment our understanding is that the majority of neuroendocrine tumours are sporadic, and what I'm focusing on, as I say today, is the ones that are passed on. It's really, really important to recognise these situations where things are passed on. Hopefully that'll become evident as I go on here. So just in terms of the talk, I'm going to go a little bit over the background, the basics of genetics, the biology. There'll be people in the room who know a lot more about that than I do, but I'll go over that quickly so we can understand a bit about what I'm talking about. I'm going to talk about 2 particular genetic issues that I think we understand perhaps better than we do other ones. Again, everything's in its infancy here. But also I think these reflect a little bit about how endocrinologists and associated specialties really think about these issues currently and the sort of experiences people might have going through life with these things. We'll talk about some other hereditary NET syndromes as well. And I'm going to finish off by talking about some research that we're now doing here in New Zealand to really try and improve our knowledge. So look, again, in terms of the basic genetics, we all inherit from our parents. Of course, we inherit everything from our parents. We all inherit effectively 2 sets of chromosomes. And chromosomes, there are 23 of them, of course, and they're just big bundles of DNA. And those those chromosomes we can break down into different genes. And each gene, of course, codes for a different protein effectively. So we inherit one version of a gene from mum and one from dad. We talk about alleles, which means that although we all inherit the same set of DNA effectively making us humans, each gene might be slightly different, and that might be different in terms of differences in hair colour and height and personality, all sorts of things. But it also might be different in terms of specifically how a particular protein behaves. And what we're talking about in terms of inherited issues really is that we inherit a gene from either mum or dad that doesn't quite do its job properly effectively. That may not be a problem because obviously we have 2 genes, but then as life goes on and we start to lose, all of us lose DNA and lose gene function as we age, we might end up without any of a particular gene in parts of the body, and that's when things might come to cause issues. So we know that the tumours and cancer in general are things that tend to happen to us as we get older in life, and that's why that is. We've got protection in place. And people who have genetic reasons to develop these tumours may be predisposed a little earlier in life for that reason. Now, most of the syndromes that I'm going to be talking about today, in fact all the syndromes that I'm going to be talking about, and generally speaking, most genetic syndromes are what we call autosomally dominantly inherited, which means that if you inherit the change in the DNA as is here, there's about a 50% chance essentially of you passing it on. So it means you only need to have one version of that gene for that to possibly express itself throughout life. And there are different ways in which genetics can play out. I'll use a few of the terms during this talk as well that I think are really important to understand. So first of all, we talk about variations or variants in DNA. Now again, we've all got different DNA. That's why we all look different from each other. And when we go looking at a particular gene, let's say, for example, we think a family has a particular genetic syndrome, and we look at that gene, we're probably going to find differences between that gene and the next person, and so on. A mutation, however, is where there's a change in the DNA that's actually led to some dysfunction, led to some disease or something else. And that's what we're often differentiating between. And again, with some genetic syndromes, we're a fair way down that road, and with others, we're not yet. So we can say, yep, there's a change in this DNA. We don't yet know whether that's going to cause any issues at all in a family. And geneticists and people who understand these things, again, a lot better than myself, will go off and do all sorts of clever things to look at that, to elucidate it. So they'll look within families and see whether a particular type of gene, what we call segregates in the family. In other words, those who have a condition have that gene, those who don't. We'll look to see if we can show the effect that particular genetic change would have in things like animal models, for example. So there are lots of ways of doing that. And the final thing as well is a term called penetrance. And what that means is that if you have a particular gene, if you have a particular mutation, so we believe that's then going to predispose to disease as opposed to just being a variation, how likely is that to cause an issue throughout lifespan? And that will be different from case to case, from gene to gene. So some genes are 100% penetrant, other genes may be far less than that. And that's really important when we're thinking about surveillance. So look, in terms of the couple of syndromes that I want to just go over here that I think reflect what we're talking about, we're going to start by talking about multiple endocrine neoplasia type 1, which I know we've already heard a bit about today already. And a couple of things I want to say before I start going into detail here. First of all, everybody's different, of course, and genetics is no different at all. So I'm going to talk about general concepts around this, but all of my patients, all the families I look after, anybody in the room who's experienced these sorts of things before will have a different story, and that's fine. Of course, that's healthcare in general. And the second thing as well is, like a lot of neuroendocrine tumour medicine in general, actually, there isn't always fantastic evidence behind a lot of what we do here. So I'll tell you what I do, and I'll show you what in Wellington, and we're relatively, we try and be as standardised as we can around the country, but obviously we don't always succeed with that, what we do. But again, if anybody's experienced this overseas or in New Zealand, you may have a very different approach, and I'm not saying for a moment that this is any better. We don't have that evidence at all at the moment, but I'll show you what we do. So multiple endocrine neoplasia type 1, it results from a change in a protein called menin, which is on chromosome 11. And what menin does is it helps with DNA repair and recovery. And so if you have a change in menin, then you're more likely across a lifetime to develop some endocrine issues. And what we're interested in really is the parathyroid, pituitary, and then in terms of the neuroendocrine tumour aspect, more specifically the pancreas and duodenum. And we make a diagnosis of familial MEN1 if somebody has at least two of those issues and a first-degree relative also has one tumour. Now, we see a number of different issues with MEN1, and what this diagram here is referring to is that this number here is the likelihood, if you have MEN1, of developing an issue in this area across your lifetime. And this number here is, if you're an endocrinologist like myself, and I see a lot of people with parathyroid dysfunction, for example, how likely that person is to have MEN1. So, in other words, how much of what we see is actually sporadic and not genetically related at all. But you can see again, we need to be aware of parathyroid, pancreas and duodenum in particular, but also pituitary. And there's a long list of other things as well that we would be looking out for in terms of surveillance that we recommend. So we've known about MEN1 as a syndrome since the 1960s, 1950s actually. We've known about the genetic cause since about 1998. And since that time, hundreds of different specific mutations have been identified. So we can generally identify the cause and a gene that's driving this nowadays. And what's become apparent over the years is that the time in life at which we might see issues will vary person to person. And a lot of the testing, a lot of the surveillance that we do in terms of when we start surveillance in life, when we do, how frequently we do imaging and so on, depends on that. We nowadays, now that we've got a genetics test we can do biochemistry and so on, we're less reliant on symptoms. And again, I know this has come up previously as well about how do we find things as early as possible. And certainly in the context of genetic screening, we are using things that we wouldn't want to use at a population level. They wouldn't be good enough, but within a family where we think there's a higher risk, they may well be. So we're doing a lot more of that nowadays. But previously, when we'd be much more reliant on symptoms, we would use things like this and realise that actually, for example, parathyroid issues in MEN1, typically that might be evident by the age of 40. So if I see a family, for example, and I'm thinking about MEN1, but a person who I think probably is affected with whatever's going on has not got parathyroid issues in their 70s or 80s. That make it less likely. So we do structure our genetic testing a bit around that. But again, everybody's different, and this is a study from one large group in France just to show that although this is the overall prevalence of these types of growths in this cohort, some people just had parathyroid, some people just had pancreatitis, some people had nothing, of course, some people just had pituitary. So there is big overlap here. And again, we have to screen with that in mind. So just going through all the different bits and pieces. Now again, for many people who have a sporadic neuroendocrine tumour, a lot of what I'm about to speak about now wouldn't be relevant at all, but just to get a bit of a feel for what we're thinking about in terms of the overall screening. So parathyroid issues. So your parathyroid glands sit here in the neck. You've typically got 4 of them behind the thyroid gland, and their job is to regulate the level of calcium in your bloodstream, and to do that by regulating the levels in the bones and the urinary control of calcium too. And what we see, and this is actually a very common condition. Lots of people, I imagine in this room, will develop an overactive parathyroid gland as we all get older. Very, very common. And again, a really important thing I think to be bearing in mind when we're talking about MEN1 here is this is a benign condition. This isn't a tumour in these glands. What we see here as these become dysfunctional is the tissue swells. The parathyroid becomes what we call hyperplastic, which means that the cells swell. It's not a tumour as such, and it's very much a benign issue. But the hormonal complications can be real, and we need to think about those. And so we screen for this. We measure calcium. We measure parathyroid hormone itself. We don't always need to treat this. And again, I suspect a little bit like a lot of your experiences here in the room, this is something we might be watching over many, many years without doing anything at all about this. But occasionally we do need to intervene, and surgery to remove the parathyroid gland that's misbehaving is what we do. If somebody has this sporadically, typically just one gland's involved, but in MEN1 and other syndromes like that, it's generally all the glands. And so what we'll do is at the first point in time that somebody needs an operation, we'll generally we'll remove more than one of the glands, typically actually 3.5 of the glands, and leave one gland either in the neck or somewhere else in the body. We can get to it relatively readily. So that's one thing we've got to think about. The pituitary is the next organ I'll talk about now. So your pituitary's up here, behind your eyes, behind the nose, in the back of the head, underneath the brain, I beg your pardon here. And it's the control centre for lots of hormones. It either stimulates other glands around the body or directly produces hormones. Things like sex hormone regulating hormones, growth hormone, prolactin for breast milk production, steroids, thyroid hormones, all sorts of bits and pieces. Now, growths in the pituitary gland are actually really common. Okay, this is an MRI of somebody's pituitary gland here. You can see we've zoomed in here. And this little thing here is a little pituitary growth. And these are really, really common. So if I scanned 100 people coming to my hospital tomorrow, an MRI scan over the age of 50, about 10 of them would have one of these things. Very, very common. Mostly we don't identify them throughout life at all. And again, these are almost always benign. Okay, so the issues relate to the hormones and the possibility of things getting bigger over the years, but not to it becoming more cancerous. This, as you can, I don't know if you can make this out here, but this is a much bigger growth. And this is going to cause some local compression issues as well. So we need to think about both these things with these types of growths. Now, these a little bit like the pancreas and the duodenal and other nets that we think about in the gut here, these can also produce hormones that those tissues were doing in healthy times as well. And there are a few syndromes that we look out for. For some of the things I'm doing when I'm seeing patients in clinic, and some of the things I'm looking for when patients come to, and I'm thinking, is there a genetic issue going on here, are some of these syndromes. So we have a condition called Cushing's syndrome. People may have heard across over the years as well. And this is where your body's making too much steroid. And this gentleman has Cushing's disease. And this is, again, as a result of a pituitary growth here. And these people might have a tendency towards weight gain, diabetes, blood pressure issues. And very specifically as well, because of course that's quite common throughout the population, they might have pink striae, stretch marks in the abdomen. They might bruise really, really easily. And they might have, this isn't very clear here, sorry, but they might have muscle weakness as well. So standing up from the bed, lifting the arms up becomes very hard. So we're going to treat for that reason. But again, this is a benign type of tumour. And the second type of functional tumour you might see as well, causing a syndrome, is a condition called acromegaly. And this is where you produce too much growth hormone. Now, again, we all need growth hormone. In childhood, it does exactly that. It causes growth. In adulthood, it's more to do with tissue repair and maintenance. But when somebody starts to produce excess growth hormone, If it's happened before they've hit the end of puberty, they're going to be a lot taller than they otherwise would be. And if it happens after puberty, then some of the other features might be more common. And what we see is some changes in the skeletal tissues in the face, and the hands and the feet, essentially. So we're looking out for all these features, again, on the basis that we want to identify this as soon as possible and treat it and resolve it, essentially. Moving on to the pancreas, we do see quite a lot of pancreatic endocrine tumours in MEN1, and one of the difficulties I'll touch upon later here is that most of these will do nothing across a lifespan at all. So we could leave these alone, they won't make hormones, they won't get bigger, they won't become cancerous, and they'll do nothing at all. And obviously what we want to try and find is the ones that might do that and treat them very, very early. So the difficult ones, the ones that are not making hormones, and again, this is the case with sporadic pancreatic tumours as well, because they might stay hidden for a little bit longer. The ones that make hormones will often cause their own sort of clinical syndrome. We've heard about this earlier on from one of the speakers, but typically we might see elevated levels of gastrin resulting in greater acid production, or elevated levels of insulin, which might present with a low blood sugar. They're by far the two most common. But much, much less commonly, we might see elevated levels of glucagon, VIP and somatostatin. Again, we've heard about those. I won't go over those just now, but they cause very typical syndromes that we're on the lookout for. Now, we might screen for those, and again, this will be familiar to lots of people in the room. We might look at those with lots of different techniques, CT, angiography, endoscopic ultrasound. We've got some functional imaging down there as well. But again, as I'll come back to later on, one of the difficulties we have here is that if we really aggressively look for these things, we're going to find little bits and lumps and things that don't mean anything at all. And again, that's the case in medicine generally. I've shown you a picture of the thyroid gland earlier on, up here in our neck. By the age of 50, at least half of us will have a thyroid nodule, okay? And most of those nodules will do nothing throughout life. Very few are cancerous. But if we start scanning, and this is in the general population, so this isn't MEN1, if we start scanning necks, we're going to find lots of things that have no bearing on that person's health at all. And so this is the same policy here. We're trying to say, we want to recognise things really early and cure things, essentially. But we also don't want to put ourselves in a situation where we're going to be performing unnecessary tests, unnecessary surgery that's not going to be of any benefit to that person at all. There are some other non-endocrine manifestations in MEN1 as well. And again, if you see somebody like myself, these are the sorts of things we look out for to say, if somebody comes to me with a pancreatic endocrine tumour, are there any other features to say, that's more likely? So I will say to patients, has anybody in the family ever had lipomas? These are lumps of fat underneath the skin. They can be anywhere, actually. They're very common, but a lot of us have those anyway. 5% of the population do. But they're more common in the context of MEN1. Has anybody had what are called facial angiofibromas? These are quite uncommon generally, and they're more common in MEN1. Collagenomas, which sit over tendons and other muscles. And there are some other features as well. So these are the sorts of things that we will look for. And this is the same with all syndromes. There are little niche findings, so to speak, that don't necessarily cause any problems at all, but will help us to recognise and identify people in whom we'd like to do some further testing. So in terms of genetic screening for MEN1, in terms of how this works at the moment, most new people I'm seeing nowadays with MEN1 have been diagnosed through family testing. So their parents or grandparents were diagnosed, and we're now screening and catching that up. Obviously, in historical times, that wasn't the case. We're meeting people for the first time, meeting that family for the very first time. About 90% of most genetic issues are inherited, as I say, from mum and dad. There's a small proportion, maybe 10%, where that's not the case. The mutation has happened spontaneously in that individual, so we have to bear that in mind as well when we're thinking about family history being important. But if I suspect MEN1 or any other genetic syndrome for that matter, or I know somebody has a family history of that, we'll get our genetics service involved. Now in New Zealand, we're divided up into 4 in terms of genetics, so there's basically a quarter of the population. So we have a very good relationship with the Central Genetic Service in Wellington. We meet once a month for an MDM, but the genetics counsellors will meet with that person first of all and go through all the implications of what genetics testing involves. I've spoken with people today about insurance issues around that, for example, around finding, again, things we weren't looking for, all sorts of bits and pieces. So they'll go through that first of all. And then if they then consent to the test, they'll provide a blood sample and we can do that test. And our testing goes either locally in Wellington or goes to Brisbane. So these are the criteria that we would use. And what we've done in Wellington is we've really standardised with our genetics service when we're going to do genetics testing. So I worked in London a few years ago, and when I came back to New Zealand, when I came home to New Zealand, I was really keen to try and standardise this, because a lot of people in Wellington, and I know this is the same in Auckland and Christchurch and every other centre as well, who should have been tested were not tested. And I think that's partly a fault of us as doctors. We weren't thinking about it, but also partly a fault of the fact that we just didn't have the resources, and these things are quite costly. So we're trying to really standardise this now and say, yep, if somebody meets these criteria, we're going to get testing organised. That's really, really helpful. And then in terms of family members as well, because these are autosomal dominant inherited genes, essentially what we'll do is it's called cascade screening. So let's say, for example, an individual has been confirmed on a genetics test of MEN1, we'll then cascade out from that person to potential carriers of that gene. So siblings, children, and so on the basis that if you don't have that gene, you can't pass it on. Okay, so we can stop there in terms of testing. And if you do have that gene, then we're going to carry on testing other family members who potentially might have it as well. And it just makes the whole process much more effective and efficient. So it looks, again, surveillance that is recommended. Again, there's very little of any evidence behind this at all. So this is the current Endocrine Society guidelines about when in life we should start screening, and what we should be doing in terms of blood tests every year otherwise, and what we should be doing in terms of imaging. Now, again, very little prospective evidence. So wherever you guys are, if a genetic change is known in the family, what you probably receive may be very, very different. Some of the key principles we work on here are, again, we want tests that are going to be really helpful. So we don't, for example, do steroid measurements every year, because that's a pretty lousy test as a screening test. We look at symptoms, but we do use the other proteins that we're measuring. And we don't use CT every year either, because you're going to very, very quickly expose that person to a lot of radiation. And we know that's the case in things like adrenal medicine, for example, where recommended guidelines around surveillance using CT imaging actually do increase that risk over time. So in all my families who I look after with suspected or confirmed genetic changes, we'd like to use MRI or ultrasound, non-radiation based imaging whenever we possibly can. Obviously bringing in other imaging when we need to, if we actually have concerns or we're following a particular tumour, for example, but the surveillance is MRI. One of the difficulties here is, again, we'd like to think that all these techniques are the same. We're looking for slightly different things maybe, but that's not the case. We're going to see different tumours, we're going to see different pathology with different techniques, and we know that if we do MRI scanning, we're not going to see everything, we're not going to see the same things we would do if we did CT or endoscopic ultrasound. And that's something we have to accept. But the evidence would suggest that the things that are significant we do still see, and that's really what we're looking for. So in Wellington, and again, this is reasonably, well, we've tried to make it as standardised around the endocrine centres around the country. There's not many of us, there's only about 40 endocrinologists, so we can sort of get together and do this. This is what I would hope most people would be receiving as a bare minimum, essentially. Again, this is surveillance. So if we were aware of an active tumour, things are going to change, of course. So we do an annual measurement of those blood tests, and I organise an MRI every year effectively. So the abdomen once a year, the chest and the pituitary every second and third year, and then we do other imaging as required. So look, I think before I finish the MEN1, I think that the really important thing to say here is that it's really important that we identify genetic changes where they exist. And MEN1's a great example, because what we found over the years is that it makes a huge difference to outcomes. And in all the centres now that see a lot of people with MEN1, the surveillance has massively changed outcomes. You know, we expect people now to essentially live a healthy life in terms of duration and everything else, and we're going to, of course, support that person through that process. There are some particular tumours that develop within MEN1 on occasion that, of course, need a bit more intervention, but actually a lot of what we're doing is supporting that person across a healthy lifetime and turning it more into a chronic sort of issue that we're dealing with. And that's really the focus here. So I think, again, really illustrates the need to recognising people and getting surveillance underway. The other thing I'd say as well is when I'm meeting people for the first time and we've diagnosed this for the very first time, it's not uncommon at all for me to hear that granddad, for example, had a really nasty outcome in the 1940s and 1950s. And a lot of what I'm doing early on, and we had obviously the psychologist talking this earlier on as well, is saying, look, we need to acknowledge that reflects the genetic issue here, but so much has changed in the last few decades. And even in my career, I'm relatively young as a consultant, the outcomes and the treatments we have just changed exponentially. So, we don't want people to focus too much on previous generations' experience and to say we're starting afresh here. And again, we're at a point in time we can survey from a very young age, we can detect things when they're tiny, and we can generally cure these things as well. And that's the sort of mode or method we try and stick to. So I better move on. The second group I'll talk about now are genetic changes that predispose to pheochromocytoma and paraganglioma, which we've also did a little bit about this morning as well. And again, this is an area that's evolved massively in the last 5, 10, 15 years, based actually a lot on research that's happening in our part of the world as well. So these are tumours of the autonomic nervous system. This is the nervous system that you're not consciously regulating, but it's regulating things like blood pressure, sweating, digestion, and involves the adrenal glands, which sit here, and then all of the sympathetic and parasympathetic autonomic nervous system in the mediastinum and up in the head and neck. And these are not too uncommon tumours in terms of sporadic causes. And again, what we've realised in recent times is genetic causes are far more likely than we once previously thought. As we heard about earlier on as well, the autonomic nervous system talks to itself and talks to the tissues via hormones like adrenaline and noradrenaline and dopamine, and that might either be connections between nerves or at an organ level. And sometimes when people develop tumours in these areas, that they might produce excess levels of those hormones. Actually, more often than not, that doesn't cause any clinical features, which can make these quite hard to find sometimes. But we can often measure hormonal changes if we look for them. So we're going to be looking at metabolites of adrenaline and noradrenaline and dopamine. And again, people might be familiar with this as well, but we're going to be using urine and plasma assessments for that. And that's changed over time. So nowadays, people may have experienced the cumbersome 24-hour urine collection tests in years gone by. We've mostly moved on from that now, apart from particular situations, and saying actually blood tests are generally more accurate at picking hormonal changes up. So we're hopefully causing less practical issues as well. So again, over the last few years, we've gone from saying about 10% of people with a pheochromocytoma or paraganglioma may have had an underlying genetic change to saying that actually in some situations, more than half of people will do. So if somebody's got a family history, if there's bilateral disease, if there's more than one primary, it's actually quite likely. So we've really understood a lot more. And succinate dehydrogenase, which is probably the area we understand most about, again, still not a huge amount, is reasonably well described now. So we'll look for particular genetic changes. And we have, over the last few years, have been able to identify particular changes, gene changes, that might then lead to a syndrome. So we know, for example, where paraganglioma are more likely to develop in the body. We know, for example, whether other things like gut tumours are more likely to occur. We know, again, a little bit about whether things are more likely to respond to treatment as well. So it's really helping to frame the overall discussion here. So again, in our region, and again, this should be pretty standardised now, if somebody presents with a paraganglioma or pheochromocytoma, we've got really clear criteria for who should get genetic testing. So, and the criteria essentially are if they're under the age of 55, if they have features that increase the risk, so certainly a family history, more than one tumour, sometimes aggressive disease as well, then we're going to organise genetic testing. What we do is we take, if somebody's had an operation, we take the tumour first of all and we stain it to see what it's doing and what it's not doing. And if there are any enzymes missing from that tumour, that can point us in a certain direction. And then we get a genetics test done. And again, whilst a few years ago we would have said, right, we're going to look for, let's say, an SDHB mutation first, because that's the most common. And if we don't find that, we'll go on to SDHD and then SDHC and so on. What we're now doing is we're using a panel test. So we're through colleagues in Sydney, actually at the moment, we're saying, let's look at the 14 genes that might be driving this and look in detail. And that's really making the whole process for patients and for us far more efficient and far more rapid as well. So again, this will differ around the country, don't get me wrong, but in Wellington, what we try and advocate for really is catching up once a year or thereabouts, although people are obviously always welcome to contact clinics and contact us in the interim if there are concerns. And we complement that with a blood test measuring chromogranin A, people will be familiar with, of course, plasmaepinephrines, and also 3-methoxytyrene, which is a metabolite of dopamine. So we do that every year on a blood test. And then we do imaging as well, and that's changing a little bit. There's some really, really good information from studies in the Netherlands and in America, for example, just trying to define how regularly we should be doing imaging. And so at the moment we're doing an MRI from here to here, so it takes quite a long time, a good hour or two to get that done. Every second to third year, and that covers all the other areas we're interested in as well. So that would be the general process that we'd recommend, and again, that's hopefully relatively standardised. Again, as with everything else, we have to fight for the resources and the time, because you can imagine that me saying, so I look after probably, I don't know, between 30 and 50 people with these sorts of issues. So you can imagine I really bug my radiology department by putting in a request for a skull-based pelvis MRI every year. But again, people come on board and they say, yeah, we can recognise the benefits of this. There's really good evidence now to show that if we find a paraganglioma and it's this big, we'd be very hopeful we might be able to even cure that. And if we find it and it's much bigger, then the treatment might be a little bit different. So you have to bear that in mind. So just very quickly, just touching upon other inheritable endocrine neoplasia as well. So this again is something that in many ways is in its infancy. And I've already spoken to people today about how little we know about other parts of the body, for example. But in terms of the syndromes that we do recognise relatively well, multiple endocrine neoplasia type 2, what we used to call 2A, increases the risk of pheochromocytoma, medullary thyroid cancer, and parathyroid disease. What we're now calling MEN3 used to be 2B, is medullary thyroid cancer, pheochromocytoma, and some of the changes there. MEN4 is a different genetic change again that we're now seeing all over the world, including New Zealand, where non-endocrine issues, colorectal cancer, melanoma, thyroid nodules, non-classical endocrine things are probably part of that spectrum as well. So there's quite a broad range. And again, what we're doing in the clinic is trying to say, well, this is what I think is more likely here, and going down certain avenues. We heard earlier on as well about a couple of other genetic changes that we don't think of primarily as being endocrine issues, but might increase the risk of endocrine tumours. So neurofibromatosis, there are various forms of that, causes, it doesn't project very well, does it? Sorry, but these neurofibromas on the skin, axillary freckling and what are called café au lait, pigmented spots in the body. There are lots of other things that go on with that. And we do see an increased risk of pheochromocytoma and duodenal and pancreatic endocrine tumours with that. So we're trying to be alert for that. And we would screen people as well with those things. And we see von Hippel-Lindau syndrome as well as another sort of representative situation too. So again, involves central nervous system changes and changes in other organs around the body. So what we try and encourage people to do is say, look, if somebody presents with a pancreatic endocrine tumour and there's a family history of hemangioblastomas or something, other tumours, just bear these things in mind and just sort of flag things up and get the geneticist involved. These are not common at all, and it's hard to get people broadly thinking about these things. So look, in New Zealand, we're getting a bit of research underway now, and this is something obviously I'm interested in, but certainly other people are as well. And at the moment we have very little evidence at all as to how many people in our country might have these issues. We just simply don't know. If we go based on international numbers, these are the sorts of numbers we might see in New Zealand. So 1 in every 10 to 100,000 people may have MEN1, for example, but it could be a lot less, it could be a lot more. We talk about founder effect, which is where if somebody with a particular genetic change moves to a region, that the prevalence, of course, will increase in that region. And people may be aware that in Tasmania, in Australia, there's a much higher prevalence of MEN1 in that area because it's an island community, essentially. So we do see these founder effects as well, which can change things. But you can see we go from reasonably common in the endocrine world, that is anyway, to things that are really quite uncommon as well down here. So we have to keep our wits about us in terms of thinking about things. And these are the sort of projected numbers we think about in New Zealand in terms of people who may have these genetic change we need to be aware of. So just to finish off then, so what we have been aware of for a long time is that first we don't know much about genetic causes of endocrine tumours in New Zealand. And secondly, as has already been touched upon really well by Simone as well, people who have these genetic changes are not really able to participate in research to the extent that we'd like. And actually, a lot of trials overseas have not had any New Zealand participation whatsoever. And again, as Siobhan and I have talked about a lot over the time, although we'd like to think there's good standardisation in this area, that's not the case. People are getting quite discordant treatment and surveillance depending on whether Wellington or Christchurch or wherever. It does change. So we got ethics approval to get this study going earlier in the year. This is the Familial Endocrine Registry New Zealand, or FERNS, and it's based on other similar models that are in place already in New Zealand that have been really effective. And essentially what we're doing is saying that people who have these genetic changes, clinicians, support organisations, anybody really can advocate for that person being referred to the registry. And this is people who have a confirmed genetic change that predisposed to endocrine changes, or where it's really strongly suspected, again on the basis that we actually don't know everything yet at all, and we need to be thinking more broadly about what genetic changes do we not know about yet. We're going to physically, this is a registry, so it's a database of details that we keep locked on a university server. We've got a governance group of researchers like myself, so endocrinologists, but also geneticists, patient advocates, paediatricians, all sorts of people who are involved in the management of patients with genetic issues, who are overseeing the whole process effectively. And what we're inviting people to do now, and this is up for enrolment in the Greater Wellington area. So we cover in areas of the lower part of the North Island, Upper South Island, and also in the Waikato area as well. So we haven't got locality beyond that, but we are going to do that. It's going to be a national thing. What we're inviting people to do is to consent to have their details maintained in this registry. So again, it's all completely secure and confidential, of course, on the basis that we can then over time describe what we're seeing in New Zealand, because we don't know. But also we can conduct our own research and invite people to be involved in research that's going overseas. So I collaborate with Australian, Canadian, American researchers, guys back in London, who would love to be able to invite people in New Zealand to be involved in their research as well. So we're hoping it will really enable that. So yeah, again, I think I've probably covered that already actually, really, but it's something that we feel is really important whenever we're dealing with very rare conditions, and whenever we're dealing with situations where you actually need almost continents worth of people to be able to do really good studies as well. Research and registries are the way forward. So I'm very happy to talk with anybody about this afterwards as well, but this is something we have got up and running now. So I think I'll probably finish there. Again, I'm going to be around this afternoon, so if anybody wants to come talk about their personal experiences or any questions, feel free to. I obviously can't cover everything in one talk, of course.